Pregnancy and the heart. Etiology. Normal physiological changes in pregnancy include decrease in systemic and pulmonary vascular resistance, increase in heart rate, blood volume, large shifts after delivery, and cardiac output. No significant change in BP. Anemia, caused by increased blood volume and/or hematinic deficiency. These can all cause problems in women with cardiovascular disease. Clinical presentation. Fatigue, mild dyspnea, ankle edema, palpitations, usually ectopics, and postural dizziness are all common in normal pregnancy, but likely to be more severe in those with cardiac disease. Physical signs. The following are common in a normal pregnancy. Third heart sound. Soft systolic flow murmur at the lower left sternal edge. Mild ankle edema. Look for signs of worsening cardiac failure and/or exacerbation of the physical signs of particular cardiac lesions. Investigations. To exclude cardiac disease, conduct the following: echocardiography to check for ventricular function and valvular abnormalities. ECG over 24-hour tape to check for arrhythmias. CXR is rarely clinically indicated, but should be performed if it is because the dose to a screened fetus is negligible. NB. In a pregnant woman, a 12-lead ECG may show a minor axis shift or nonspecific ST changes in the left-sided precordial leads. These usually resolve after pregnancy, but may recur in subsequent pregnancies. Prognosis and treatment. In a patient with pre-existing cardiac disease, the ability to tolerate pregnancy is related to the following: cyanosis, pulmonary hypertension, hemodynamic significance of the lesion, pre-pregnancy functional status. High risk. Primary pulmonary hypertension or Eisenmenger's syndrome. There is a 50% maternal mortality rate and patients should be strongly advised to consider sterilization. Mitral stenosis. This may present for the first time in pregnancy with pulmonary edema secondary to increased cardiac output or an episode of atrial fibrillation. Treatment consists of diuretics to clear the pulmonary edema, and digoxin, or beta blockers to control heart rate and thereby improve atrial emptying. Mitral valvuloplasty may be necessary during pregnancy in rare occasions. Aortic and pulmonary stenosis. Gradients are exacerbated by decreased vascular resistance. There is no effective medical therapy other than supportive. Marfan's syndrome. There is an increased risk of aortic dissection. Those who already have echocardiographic evidence of aortic root dilatation more than 4.5 centimeters should be advised against pregnancy. Intermediate risk. Coarctation of the aorta. Risk of aortic dissection. Hypertrophic cardiomyopathy. Cyanotic congenital heart disease without pulmonary hypertension. Note increased risk, 40%, of fetal death if mother is cyanotic. Low risk. Well-tolerated valvular regurgitation. Septal defects without pulmonary hypertension. Totally corrected congenital heart disease. Prosthetic valves. Bioprostheses do not require anticoagulation, but pregnancy reduces their lifespan. There is no consensus on the optimum management of anticoagulation in pregnant women with mechanical valves. There is the concern that heparin is not as effective as warfarin in preventing valve thrombosis. NB. Antibiotic prophylaxis is recommended for vaginal delivery in cases at high risk of endocarditis, prosthetic valves, prior episode of infective endocarditis, complex cyanotic congenital heart disease and surgical shunts, and for instrumented delivery in any cardiac lesion, but not for cesarean section. New cardiac disease in pregnancy. Thromboembolic disease. Thrombolysis should be used for a massive life-threatening pulmonary embolus, as in the non-pregnant patient. Myocardial infarction. This is rare in pregnancy but is associated with considerable mortality. Atheroma is responsible for less than half of instances, and coronary artery dissection is more common than in the normal population. Ideally, the treatment should be urgent coronary angiography and intervention if needed. Aspirin, nitrates and beta blockers may be used. Angiotensin-converting enzyme inhibitors and statins should be avoided. Peripartum cardiomyopathy. This presents as dilated cardiomyopathy in the third trimester or in the first 6 months postpartum. Hypertension. Hypertension may be chronic, i.e. predates the pregnancy or develops before 20 weeks, or pregnancy-induced, part of a spectrum that includes preeclampsia. NB. Important information for patients. Recurrence risk of non-syndromic congenital heart disease in the baby is 3–5%.